Hey guys, I'm Dr. Danny Shaban with Dominion Women's Health, and welcome to our podcast with still no name to it. No one's giving me any good names to it, Melissa.
Oh, you're kidding.
So we got to figure it out.
All right.
So today what we're going to talk about is birth control, and we're going to try to do a pretty quick thing on birth control. And I know that I'm going to end up having to do another podcast because everyone's going to say you missed this one or missed that one. So back in residency, every physician that's in training in OBGYN has to do a research project. And that started back in the late 80s, 90s in doing research. So my research in my residency was low dose birth control or contraceptive. So we were talking about the risks and benefits of low dose birth control. So when I have a patient that comes in for contraceptive management, and I love this, whether the patient's coming in for an annual visit, a new GYN visit, or even an obstetrical visit, and we're talking about after she delivers what birth control. I like to talk about all the different options in birth control. So what I'm going to probably do is start off with the worst and work my way to what I think is the best. So back in the 80s, the flavor of the month or the best thing gynecologists and primary care loved was this thing called Depo-Provera, which was a shot. And I had written,
exists.
Yeah, it would still exist, sad to say. And one of my professors in residency and I did a paper on the Depo-Provera. I called it the devil drug. But so the big thing about Depo, and it came into fashion, is that you could give it to a patient. It lasted for 3 months, and it kept them from having a period. It was a good cycle stopper, and it prevented pregnancy by over 99%. So they were like, winner, take it, it's great. Well, what they didn't tell patients is that, oh, by the way, this drug we're giving you is all progesterone. If you have a history of anxiety and depression, it can make it worse. If you have a weight issue, you're going to gain more likely 7 to 10 pounds a year on this drug.
Wow.
If you have a history of ovarian cysts, ding, 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 you're going to get bigger cysts. If you have a history of PCOS, it's going to make it worse. So if you have a history of osteoporosis or thinning of bones, it's going to make it worse. It was just like one crap after another, but no one ever talked about it.
Wow.
So, and I knew that there was something up when I was in med school and I did my rotation at the health department, and the providers there and the nurses were like, give her her Depo, give her her Depo. And the only reason why is they didn't want to see her again for 3 months. Well, that's sort of BS. You weren't giving the patient what was best in their best interest. So in 1998 or 99, Dr. I'm not going to mention his name, but he was great. He was an amazing PhD. He and I did a paper, and we went to Chicago to present it. And it was on the risks of Depo-Provera. And I got lambasted presenting in Chicago at the American College of OBGYN by all these older doctors saying, you don't know what the hell you're talking about. It's a great drug. So then 6 months later, the FDA put a black box warning on it and said, these are the risks. And if you have a patient on it, you should get a bone density. And it went from the #1 prescribed drug to now probably 5 or 6. But there's still people that prescribe it.
There are.
And I'll get patients all the time that come in and go, I don't know why my daughter has gained 30 pounds since high school and she's always crying. And I'm like, so let me guess, she has Depo. And the other crazy thing is part of my research is we noticed that when that came out, the Depo got switched to other things. And we're going to go through that. So besides Depo, I always tell patients about it, but I tend to shift away from it. Is there someone that I would give it to? I mean, if you have major risk factors that you cannot take any other hormone, I might. But honestly, I probably prescribe 1 Depo a year, and that's a patient who might be adamant that she wants it. The next thing that's available is the Nexplanon or implantable device, and it's subdermal and it goes under your arm. There was one prior to it that had multiple ones that went under your arms. So the Nexplanon is not a bad form of birth control. I know that you're sensing I don't like it, which I don't, but it's not a bad form of birth control. It's progesterone only, again, And it's good for someone who's non-compliant with taking medication, who can't take an estrogen product, who is not good at taking the pill or the ring, and it works for 3 years. So what ends up happening is it goes transdermal, and it can cause you initially in the first 6 months or even up to a year is to have irregular cycles. So whenever I put one of those in, I tell the patient, you're going to have irregular cycles. Because initially when it first got FDA approved and people were using it, patients were coming in on a monthly basis going, I can't stand it. I'm spotting all the time. And it's your body getting adjusted. Why am I not a big fan of it personally? Again, it's progesterone. So I tell patients all the time, if you have like a hemophilia disorder or severe anemia or a bleeding disorder, I'm not a big fan of it being my first line drug. If you have a history of multiple antidepressants, anxiety medicine, it's not my first line drug. So next one, but it's a great form of contraception for patients that can't take the other ones. The next type of birth control that I talk about is transdermal, or the patch. The patch has come back on the market. Originally, I laugh about it almost, but Ortho was the first one to have the patch. And I don't know if you remember it, the Ortho Evra patch.
I do.
And Ortho thought it was the big shit on the market. So they were capturing everyone. What they failed to market, and that's how it got a bad rap, was, and the providers were prescribing it, is that if you weighed over a certain weight, I think it's like 185 pounds, you really shouldn't be on the patch because it could cause irregular cycles, or the hormones would absorb into the submucosal fat, into the fat, and all of a sudden release. So you had more patients with blood clot disorders, bleeding disorders, and it fell off the market. Well, now there's a new patch that's out, and I think it works fairly well. I like it. It's got an estrogen progesterone combination, and for patients that don't want to take a pill or the ring, it works fairly well. Why are transdermals and the ring really popular? Because you get a sustained release of hormone. And I don't know if you've ever tuned into the podcast for hormone replacement. When I say sustained release, it's not like a pill where you take it in the evening and by the morning your levels are really high and then they come back down. With sustained release with the patch or the ring, your levels stay the same. So you get less breakthrough bleeding, less side effects. So patients love it.
And you also don't have to worry about taking it every day too.
I know.
That's a huge thing.
The only downside is you got to take the damn thing off every 4 days.
Well, that's
See, but if it was a men's patch,
right,
if it was men's health,
year.
we'd have the thing where you'd stick it on a man's ass and it would stay there for a year,
Exactly.
and he wouldn't have to worry. And by the way, has anyone ever questioned why we don't have men's birth control? Why can't we have something that controls your sperm count versus a woman having to take something?
Thank you.
I bet you get more compliance
Yeah,
because man would not want to get her pregnant.
That's right.
So off subject a little bit, but so back on the subject. So the next form of birth control is the pill. And if you listen to one of my other podcasts where I start talking about birth control in the 1960s being 100 to 50 micrograms of estrogen to now being 10, birth control has changed dramatically over the years. I mean, the monophasic pills, meaning that one dose the whole month, has come out over the past 20 years and it works amazing. A lot of the pills now are 10 to 20 micrograms of estrogen, very little side effects, very little breakthrough bleeding. Cycle control. Instead of bleeding for 10 days, you have your menstrual cycle for 2 or 3 days. So women love it. What's the downside? The downside is that you can't miss pills. You can't be like crazy and say, today I'm going to take it at 6 o'clock. Tomorrow I'm going to take it at like 2 o'clock in the afternoon. You have to be in the same time frame. What are the advantages? Cycle control helps prevent fibrocystic breast disease, gives you that sense of well-being with hormonal balance. The big thing also, and patients tend to not know it until they see you for your annual exam and you discuss it, is birth control helps prevent ovarian cancer. So I explain that to patients all the time because mothers will come in and go, oh my God, you're going to get rid of her fertility. She's going to, and I'm like, no. Number one, it's going to protect her ovaries. It's going to protect her from ever getting ovarian cancer, fibrocystic breast disease, cycle control. And it's easily reversible. That's the amazing thing. Yeah. Back in the olden days, and when I started practice 20 years ago, patients used to say, well, if I come off the pill, I got to wait 6 months to try to get pregnant. No. What does a pregnancy produce? Estrogen and progesterone. what's in birth control? Estrogen and progesterone. So, and now because they're so low dose, you stop the pill within a week, it's out of your system to begin with. So patients tend to do well. So I like the pill. I think the pill works really, really well. But the other big thing is compliance. So what do we tend to do? We get patients to come back after 3 months of being on any form of birth control, because I want to see if you're taking it. Because if you know you've got some ownership in this,
Yeah.
you're going to go, oh crap, I got to go see Dr. Shaban, so I better be taking my medicine too. The next form of birth control that works really, really well is called NuvaRing. So that was back when I was in residency in 98. NuvaRing was coming out and it was really popular. I personally love prescribing the NuvaRing, the Annovera, anything that's vaginal, whether it's for hormone replacement or birth control. I love it because there's no first pass effect. And what do I keep harping in the past about first pass? First pass effect means that it's not going through your stomach acids, the food, from there to your liver to your bloodstream. When you put a NuvaRing in and women don't feel it, your partner doesn't feel it, it has a sustained release of hormones. So it starts to release hormone into your vaginal mucosa, which gets absorbed into your bloodstream. So with the ring, your hormone levels stay the same for 35 days. And then after 35 days, you start seeing your levels drop. So if you look at the package insert, it says treat it like the pill. You do 21 days in, take the ring out, and then you have your period, and then you put a new one in. That's a 28-day cycle. I usually go a little off label, but I tell patients that, hey, listen, if you're supposed to take your ring out on Friday, but you're going to the beach or you're going to a concert or you're doing something or you have a business meeting or event over the weekend, don't take it out. Leave it in until Sunday night or Monday when you come back. It gives you a 1 week window that the ring is not going to wear off.
Does that affect women at all? I mean, as far as delaying their period at all? Or
No, I mean, you're changing your cycle, meaning instead of a 28-day cycle, you have a 35-day cycle.
Right.
I mean, I think they like it a lot. The other side effect of the NuvaRing that I tell patients is your body naturally starts producing lactobacilli, which we call a natural lubricant. So women will say they feel moist or they feel wet. That lactobacilli prevents you from getting a yeast infection. So you very rarely hear about someone complaining of vaginal dryness or anything like that. So they love the ring.
Nice.
And what we used to do with the NuvaRing before it went generic is we had samples. So what I would do is I would give the patient the sample and I wouldn't have you take it home. I'd say, go ahead and go to the restroom, put this in, come back and dressed, and we'll talk. Because if I gave you the sample and you left, most likely you weren't going to try it. So when you try it and go, oh my God, I don't feel it, it works great. And they've done studies, and I'm not giving you exact numbers because I can't remember, number one, but they've done studies with the NuvaRing versus a pill as far as compliance. And if you look at birth control pills, compliance at 3 months is like 33%, where with the NuvaRing, it was above 70. So there's a huge difference because it's ease. Like if you, and this goes back to what's the difference between a man and a woman.
Right.
If you asked a man, myself, like to take a pill every single day, and I've had to now for 15 years, and the only way I remember is it's in my face to take my Synthroid in the morning. But if you tell me to take a pill every single day, I'm going to forget at least 10 days. I mean, I remember when I was in med school, I was like, how can this woman forget to take her pills? And then one day I got sick and they gave me amoxicillin. They said, you have to take this thing 3 times a day for 10 days. At the end of 10 days, I had 7 pills. I'm like, how did this happen? So compliance is hard with pills. So I give women so much credit for being able to take something every single day.
Right.
So the next thing I talk about is I tend to talk about IUDs. I truly love, other than the ring, IUDs. I tend to talk about the different types of IUDs, but the thing I love about IUDs, it's almost like, I tell patients with the NuvaRing the same thing. It's like that infomercial, you set it and forget it. Well, the IUDs are truly set it and forget it. The cool thing about the IUD, there's the one that is, I think, amazing is Paragard, or the copper IUD, or the T380, whatever someone wants to call it today. But the nice thing about the IUD, the Paragard or the copper, it's been around for over 40, 50 years, probably even longer. It is the most common birth control prescribed in the world. In the US, it's not as much. And again, it goes back to women's health care and finances. Why is it the most common in the world? I like it because it's one-time cost. This birth control works for 10 years. It's immediate. So it's like doing a pap smear. I put a speculum in and it slides into the cervix and sits in the uterus, and there's a string at the end of it. So it works immediately. The other great thing about Paragard or the copper IUDs is it's immediately reversible.
Yeah.
So let's say, for instance, you started your period today and you saw your gynecologist and they took out your IUD. You could realistically be pregnant in 2 weeks when you ovulate because it doesn't inhibit you from ovulating. So, and it works for 10 years. So I tell patients all the time, you can keep it for 1 year, 5 years, 10 years. You can, if you're not looking at conceiving anytime soon, put it in. If you win the lottery and you want to have another 2 kids, boom, take it out. It works immediate. It's got to have a downside to it. So the downside to the IUD is the Paragard especially is if you have a history of really heavy periods or really painful periods or severe endometriosis from your periods, it's not going to make it better. There's a potential it can make your periods a little bit heavier, but that's the only downside to it.
Who's your perfect patient for that style? That's going to be a non-hormonal one.
I mean, definitely my postmenopausal patient who, not postmenopausal, postpartum patient who's just had a baby, not looking to conceive in the next 2 to 3 years, she's perfect. Or if I have a patient who has a history of a blood clot or a stroke from hormones and doesn't want to take an Nexplanon or a Depo shot, which is all progesterone, but still needs birth control, copper is the way to go.
Okay.
So it's non-hormonal. It's not going to affect your weight. It's not going to affect anything else. So I'd probably use that.
Okay.
The other type of IUD that's popular, and I think it got more of its popularity from how much they put ads in the magazines and on TV and stuff, but is the hormonal IUDs. You have the Liletta, the Mirena, Kylena. I think they're another great form of birth control because they're an IUD. Now, why is it not my first IUD that I choose? And the reps always hate when I talk about this is, again, it's progesterone. I'm not a huge fan of this whole progesterone only thing. But if you're a patient who's had severe anemia, you have a bleeding disorder, you hemorrhage, or you have like severe endometriosis and you have severe pain when you have your periods, it's great. It works really, really well. The other thing I tell patients to just keep an eye on, and I watch my patients, is I watch not just your weight. Your weight's not going to be as much as like having a Depo shot or the Nexplanon, but we watch like your pelvic. I want to make sure you don't develop an ovarian cyst 2 to 3 years down the road. If you have a history of anxiety and depression, we follow it carefully. And I know people say, well, it's not a contraindication, Dr. Shaban. I go, absolutely, it's not. I'm just going by experience and what patients have. And we tend to just follow it carefully. You were getting ready to say something.
No, go ahead.
All right.
Go ahead.
So then the next form of birth control is using what has been around forever, a condom. Okay. What is an advantage of a condom? It prevents STDs. It also prevents infections. It's not a bad form of birth control. But also, the one thing I always tell patients all the time, whether you have a patch, a Nexplanon, the NuvaRing, you have an IUD, it's not going to prevent an STD. It's not, just because you're on the pill does not mean you're not going to get herpes. It doesn't mean you're not going to get HPV. It doesn't mean you're not going to get gonorrhea and trichomonas. So unless you're in a relationship that you both trust each other, you both believe in each other, I always tell my patients in general, just use a condom as well.
Yeah.
Anything else you can think of, boss?
What about getting your tubes tied?
You know, I can always forget that that's a form of birth control. I think getting your tubes tied is an amazing idea, especially if you have some contraindications to being on the birth control. There's different forms of getting your tubes tied. The one that was amazing, and then it just started having more and more side complications, was this thing called Esure, where we could even do it in the office, put a little camera through your cervix and put these coils into where your tubes were. The problem is some patients started getting like an inflammatory response, like pelvic pain, almost like a pelvic inflammatory disease from it. There was also some perforation, so it got taken off the market 10 years later. So the most common forms of tubal ligation now is sticking a camera through your belly button. And what we do is we either put a ring, a clip, or burn, or take that segment of your fallopian tube out. The big question that's asked all the time, is it going to cause me to go through menopause early? No. You're only taking the tube. Back in the olden days when they used just general heat, which was a bipolar heat, you would get a thermal spread towards the ovarian blood supply. And I would say, yes, that could affect your ovarian function. But for the past 25 years, not really. You're just taking that snippet of tube. What's the advantage of it? You're not going to get pregnant. You got great form of birth control. It also, going back to the birth control pill, it prevents or decreases your risk of getting ovarian cancer. There's a lot of retrospective studies with ovarian cancer and having your tubes tied. What's the disadvantage that I tell patients? Number one, insurance pays to get your tubes tied. It doesn't pay to get them reconnected. And don't believe this whole thing, and I go through this at least once a month. When a patient walks in and says, I want my tubes untied, it's not a shoelace, people. I don't know who came up with the word tie.
Yeah.
But then I look back at it. So what they do is they take your fallopian tube, which is straight, and they make a knuckle out of it. They pull it up, and they take a suture and tie it into a tight knot and then cut the tube in half. Even if you weren't to cut the tube, it's like a skin tag. Eventually that tube falls off where you put the stitch.
Oh, no kidding.
So to reconnect the tube, number one, it's very expensive. Number two, you're at an increased risk of an ectopic pregnancy, increased risk of blood pooling in that area, increased risk of not getting pregnant. So it doesn't work all the time. And also it's surgery. There's a risk of infection, bladder injury, bowel injury. Even though, knock on wood, it's very rare, it could potentially happen. The only thing I don't like about what's happening in our society right now with tubal ligations, and I want patients to just be aware of it, especially if you're getting a C-section and they ask you if you want your tubes tied. I want you to be really conscious and talk to your doctor about your tubal ligation, because what I noticed over the past 3 to 4 years is one of the surgical companies has come up with an instrument that we used to use in major surgery and now using it for tubal ligations, where during a C-section, if you want your tubes tied, instead of taking that small portion of tube, they use this instrument and they take your whole fallopian tube.
Wow.
So they're saying is it's quicker, it's easier just to take the whole tube with this instrument because you're cauterizing. But again, I'm thinking outside the box, and I'm like, well, wait a second. If she's, let's say, 33 years old, she's had 3 kids, she gets her tubes tied. God forbid she gets divorced, meets the man of her dreams, and wants to have a baby. There's nothing to reconnect. There's really 0.0 to reconnect. So then you have to undergo IVF. So who's happy? The IVF doctors.
Exactly.
Take every tube out of every woman. So I just want you to be conscious of that. And there is some women. I had in the past year where I've taken the whole tube? Absolutely. I've had a couple patients who have severe endometriosis where their tubes are inflamed. So when I'm doing their C-section, I'll take their whole tube. But we've had this discussion prior. So
and that's
again,
not necessarily more so for birth control. That's because they have other medical issues going on, though.
Correct. So, I mean, I think that's some of the forms of birth control. If you have any questions or anything, please reach out to us and talk to us. Our next podcast, hopefully, will be in the next week or so, and we'll have a freaking name. Melissa's not helping.
Sorry.
Anything else, boss?
No, sir. I think we're good. Thanks so much.
All right, guys. See you later.